One of the other papers that we have recently been working on, the research has been really involved in looking at the costs of doing in-office procedures. And in particular, with this particular project, we're interested in looking at the cost of in-office biopsy. So traditionally, when patients come in with lesions that are a little abnormal, we would take them to the operating room and do a biopsy. For the last several years, since we've had the technology to be able to do biopsies with distal chip scopes using side channels, we've been doing most of these biopsies in an office setting. And we've shown in the past, including some of the data that we had produced, that these biopsies are pretty accurate. Part of the problem, though, is that the biopsy forceps are relatively small, and so there can be some sampling error. And so the most recent paper that we were looking at is really looking at the cost differential and whether or not it makes sense to do these procedures in an office setting, knowing that there'll be a certain percentage of those patients that will still have to go to the operating room for full diagnostics, given that the sample sizes, or the biopsy size is relatively small. And so it's essentially a financial analysis looking at whether or not that makes sense, both as a hospital environment setting, so if you are part of the hospital or if you're an individual clinician who also happens to work in a hospital, or from the hospital system as a whole. And the second part of it was also to figure out when it makes sense financially to actually buy this equipment and how long it takes to essentially pay back the equipment, because the equipment can be fairly cost heavy. And so it's really a two-part analysis. And so the first part was to look at essentially whether it makes sense to do these biopsies primarily in the office. And in the end, it looks like it saves the hospital system a lot of money, and probably the healthcare system a lot of money, to be doing these in the office. Because even though there is a percentage of patients who you have to rebiopsy in the OR, the vast majority of patients have proper diagnostics done in an office setting and never have to go to the operating room. And then if they have to have treatment done, some of that treatment can be done in an office setting through the lasers, or can be done through radiation, and they never have to go to the operating room. So that saves the healthcare system and saves the hospital system money. The second part was looking at essentially where the break-even point comes in, where you can essentially pay back this equipment in terms of time savings instead of having to go to the operating room. And it turns out that you have to do a fair amount of biopsies to make up that cost, and it looks like you have to do close to about 20 a year for about 8 years to be able to justify the cost of the equipment. The part that we haven't really looked at is the benefit to the patient in this particular study, although that's been looked at plenty of times in the past. And if you survey patients, they will largely tell you that they would prefer to do in-office procedures. It saves them not only the cost, the expense, the time of going to the operating room, but obviously they feel it's a safer alternative than having to get general anesthesia, which would be necessary to do a lot of these procedures in an operating room setting. So patient preference is a strong driver toward doing in-office-based procedures. Also from the practitioner side, it makes a lot of sense because you save time. If you go to an operating room to do a biopsy, it can take you upwards of about an hour, hour and a half. If you do that same biopsy in an office setting, you can do that in about 15 to 20 minutes. So that savings obviously impacts how long your day is and whether or not you can do other procedures in that slot.